A great question. And our study underscores a very complex interplay between peripheral arterial disease severity, timing of medical interventions, and healthcare utilization patterns. What we see is that in a contemporary population of US Medicare beneficiaries with critical limb ischemia or chronic limb-threatening ischemia, Black patients have more advanced ischemic disease. They're younger and have a significantly higher burden of cardiometabolic comorbidities such as heart failure, hypertension, cholesterol, diabetes, and kidney disease, which are all also independent risk factors of peripheral arterial disease. And they are also more likely to be socioeconomically disadvantaged compared to white patients. And when we look purely just at the numbers, descriptive numbers, we see that Black patients have one far lower percentage of revascularization procedures in the US compared to white patients. And numbers-wise, they have a fairly similar rate of mortality. And it's once we account for their disease severity, comorbidities, younger age, and socioeconomic backgrounds, that the risk of mortality falls significantly below white patients. And what this tells us is that the patient profile of the Black patients undergoing CLTI revascularization is significantly sicker than that of the white patients with CLTI going into their first revascularization procedure. And another part of our study is that we conditioned our analysis on patients undergoing revascularization. And this is a decision that lies right at the intersection of race, disease severity, access to specialist care, physician referral patterns. And so one aspect that we do have to acknowledge is that collider bias could artificially distort that mortality comparison between Black and white patients. So higher emergency department utilization and readmission among Black patients highlight a lot of what we wanted to cover in our study in terms of inadequate access to preventative and longitudinal outpatient vascular care. And reliance on emergency care suggests that any complications from CLTI are going unmanaged until they reach a critical stage requiring an urgent intervention. And this pattern results from potentially limited outpatient follow-ups, as we found, gaps in routine vascular surveillance, or difficulties navigating the healthcare system. And what it leads to is that it places substantial strain on both healthcare resources and patients themselves. And therefore, it should come as no surprise that it leads to worse clinical outcomes, higher costs, and increased risk of severe complications, in particular, as we found in much higher rates of major amputation among Black patients. And effective management of CLTI is not just the revascularization itself, but it requires proactive, continuous outpatient care rather than episodic emergency interventions, and it emphasizes the need for better healthcare integration and coordination to address these disparities. There are some national multidisciplinary efforts ongoing, particularly the PAD Pulse Alliance, which is made up of the Society of Cardiac Angiography and Intervention, Society of Interventional Radiology, the Society for Vascular Surgery, and in particular the Association of Black Cardiologists. And this is just one multidisciplinary alliance, and the AHA also has a similar initiative ongoing to encourage the implementation of sort of a multimodality, multidisciplinary action plan to target early detection and intervention for PAD and CLTI, as you mentioned. One of them is for enhanced screening programs, so routine PAD and CLTI screening in high-risk communities and possibly in community clinics or via mobile units. We need multidisciplinary limb salvage programs that establishes integrated care models combining primary care, podiatry, vascular surgery, wound care, endocrinology, in addition to cardiology and vascular specialists to manage risk factors more holistically. And what we need also is an improved referral systems that develop clear standardized guidelines for primary care providers to rapidly identify and refer at-risk patients to vascular specialists. And finally, I think we need better patient navigation and outreach programs to overcome logistical barriers such as transportation, appointment scheduling, and follow-up care. I think our key takeaways from our study is that we have a long ways to go in providing equitable and just care for those most vulnerable patients with peripheral arterial disease and chronic limb-threatening ischemia. And we found in previous studies that that almost 70% of Black and Hispanic patients with PAD are unaware of what the symptoms of PAD are, and many of them just ascribe these symptoms to natural, aches and pains of aging, when in effect they are signs of very specific disease progression. And to be able to catch these early and to be able to treat them early and effectively for these vulnerable populations is going to be critical from a public health standpoint and from a individual care level standpoint, and importantly for policy reform going forward.